right on the speakerphone. Can you tolerate that, or do I need to do it the other way?
We'll keep you on the speakerphone unless somebody chats in and says that it's too difficult to hear. So as long as our listeners can hear, that's fine. I'm just going to go ahead very quickly through welcome because Bob Conley's already done that. But just to remind people that we have 2 webinars a month. One on Tuesday is Best Practice Nursing Home Social Work, and then the Thursday one is Emerging Issues. We are recording this session. It's being recorded right now, and it'll be up within about 24 hours. And our format is that Dr. Rosalie Kane will speak for the next 45-50 minutes, and then we'll answer questions that you put in through the chat box. So thank you for that, and thanks, Bob Conley, for pinch hitting while we were getting things ready. All right, so right now, and Rosalie, Bob has introduced you.
Yes, good.
So you've been introduced. Right now we're looking at the first slide, your title slide, Making Quality Assurance and Performance Improvement.
So I doubly apologize because I'm not advancing my own slides, and I feel quite paralyzed when I'm not. I'm going to get off the speakerphone so I can make this so everybody can hear me better, I think.
Thank you, Rosalie.
So
much better. That's
okay,
much better.
I'm off the speakerphone, and you can just go quickly over the slide with my picture, Merce.
Okay.
Kind of an old picture anyway. See, I can't see what's up there, but
it's the webinar
plan. Then we're coming to the plan for this webinar. So we're going to talk about. This is an emerging issue, obviously, and we'll talk about QAPI as an emerging issue, and I'll try to define it, talk to you about its elements and its action steps and some of the tools and resources that have been developed for QAPI, and then I'm going to go through some issues in a national demonstration of QAPI. I think that QAPI, I've told Merce and Bob that I call it QAPI because CMS ingrained it in me. But if you call it QAPI, it'll probably answer just the same. QAPI sounds a bit Disney-esque, and that's why we don't do it, like a cartoon character. I think that QAPI offers a real possibility for the improvement of nursing home care, for the improvement of quality of life in nursing homes, and a possibility for social work. But it's, and you can go to the next one, Merce. The devil will be in the details, as is always the case. So QAPI is data-driven, and it's a proactive approach to quality improvement. This is an official definition that has been developed by a CMS. And it's a comprehensive approach. Its activities are designed to involve all members of an organization to continuously identify opportunities for improvement and to address gaps in systems. That's the basic introduction. On the next slide is a way of thinking about it, comparing QAPI to quality assurance as we've always had it in nursing homes. And I don't want to, since we're a little delayed, I really don't want to waste too much time on that. The big difference is that quality assurance involves standards. The standards are written, and you assure that you're complying with those standards. Contrast, QAPI is involved with raising the ceiling of quality and perhaps exceeding minimal standards. So that's the main difference. As far as the history, you can go to the next one now. The history of QAPI, why we're talking about it right now. Well, it was embedded in the Affordable Care Act. probably not the single most important part of the Affordable Care Act, which our president is talking about today, or just has finished talking about today. But it is one of the many components that affected nursing homes. And so in 2010, in the Affordable Care Act, the statute said that every nursing home will have a QAPI program, and this would be that CMS would be invested with the responsibility for providing technical assistance for QAPI and offering up information about best practices. They would also be responsible for creating a regulation. Regulation is in place, and the regulation has not been yet, even in draft form, but it is being worked on. When the regulation is in place and promulgated as a final regulation, then nursing homes will have a year in order to get a QAP plan in place. So that so this is not strange language to other healthcare sectors. There are, I believe, 7 other healthcare sectors, including hospitals and ambulatory care centers and surgical centers and dialysis centers and hospice and home health. They all have QAPI in place. This is just bringing QAPI to nursing homes. The nursing home difference to me is, first of all, that the nursing home is meant to be a home, not just a care site. And also, in contrast to all these other settings, we have the hands-on inspections or the surveys that characterize nursing homes. That does make it a little bit different. So we're going to develop a program that has enormous capability, I think, for improving quality, getting everyone involved in quality, but there's going to be a rule about it. So if you would take us to the next slide, Merce, I just couldn't resist showing a little cartoon. So you see that Humpty Dumpty sat on a wall, and Humpty Dumpty had a great fall. And you're going along with me, aren't you, Merce? All the king's horses and all the king's men couldn't put them together again, right? You all know about that. And so what happened next? Humpty sued the king's men for malpractice, and he sued the engineer for defective design of the wall. He also sued the city for negligence. This made Humpty rich, and it made sitting on the wall never the same again, and that's the real point. If you can read this cartoon, you're seeing all the little details. The wall height can't exceed this much inches. You've got to wear your helmet. You need to get a waiver, and so on. So that's the point I'm trying to make, is that there's a little bit of inherent contradiction we just have to live with, that we want a kind of quality program that's grown in the facility itself, that's based on examining its own data very broadly, deciding where it needs to give attention, and it's going to be owned by everybody in the nursing home, but there's going to be regulation about it. So that's just something we have to live with. Okay, there are 5 elements of QAPI, and those 5 elements are sort of graphically displayed on the next slide. They're all interrelated. They don't come in any particular order, even though they're numbered 1, 2, 3, and 4. And I was going to just take us quickly through each element. The element 1 is called scope and design, and it states that a QAPI program has to be ongoing and comprehensive. It has to deal with the full range of services that are offered by a facility and the full range of departments. So the social work department will be involved. When you see something in red, I'm just calling your attention to it. And when fully implemented, the program should address all systems of care and management practices and should always include clinical care, but look what else, quality of life and resident choice. And then my favorite sentence in the whole thing, even though it's so difficult to implement, it aims for safety and high quality with all clinical interventions while emphasizing autonomy and choice in daily life for residents or residents agents. That's moving right into the codification of QAPI, this existential dilemma in nursing homes that we are trying to be as safe as possible by whatever our idea of safety is, and at the same time we're trying to offer choice to residents. It also uses the best available evidence to define and measure goals, and that's a little tricky because evidence in nursing homes has some complications. Okay, so element 2. And the other part of element 1, if you go back to it, if MERS, I don't see it there though.
Yeah, we're at
the other part of element 1 is that there has to be a plan, and the plan will be in place and will show how all the elements will be managed. Now, when we come to element 2, which is about the governing body, it's called governance and leadership. And it really is essentially saying that you really do need to have buy-in for QAPI from the highest level of governance of this nursing home. Now, that might include a corporation. If the nursing home is part of a corporation, it would include the owner. If it's owned privately, it would include the board of directors if that's the governing entity. But you also have to have the executive buy-in, which could also include a corporation. And yet every facility, the leadership of the facility also has to be involved. That would be the executive director or administrator of the facility. So it says that this governing body or administration will be developing a QAPI program that involves working with input from facility staff and from residents and from their families or representatives, and I underscored that. That's an important part for us as social workers. The governing body is going to assure that there's adequate resource, the money is there, and the time is there to involve people in QAPI and any supplies that might be necessary, and they will designate one or more people to be accountable for QAPI, which at the facility level, there was a lot of discussion about this in the technical expert panel that was working with us, and I'm sure that Bob or whoever introduced me explained that over the last 3 years I've been directing a project to assist CMS in getting the technical assistance together. And so we've had a technical expert panel, and we have talked about this a lot. Should there be a QAPI coordinator? And of course that immediately brings to mind MDS coordinators. And I think there was a hesitation to come up with a sort of one way to do QAPI, and that there had to be a person. In fact, there's kind of a hope that it won't happen that way. But on the other hand, there needs to be enough time for that person who's in charge of QAPI. And we had a lot of discussion about what that would mean. And we might have time to discuss it as a group. The governing body, this leadership, is responsible for establishing policies that will allow it to be sustainable, even if all the leadership leaves. So if you have a new administrator, a new DON, a whole bunch of other new people, QAPI is supposed to survive. And if you go to the next one, MERS, it goes on to say that they will be setting priorities for the QAPI program, building on all the principles that were identified in the design and scope. This is triply hard. I'm not only not handling my slides, but I'm not seeing all of you and your reactions and knowing whether this is coming across clearly. But what you have to imagine is that if the nursing home has a dementia unit or a respirator unit or a big TCU, all of those parts are part of QAPI. And if you have some principles that undergird your operation, that should be embodied in QAPI too. And now we're talking about setting priorities, building on those principles, and they're responsible for again, we're talking about balancing safety. It's in there twice. We're setting expectations around safety, quality, rights, choice, and respect by balancing both a culture of safety and a culture of resident-centered rights and choices. So, I mean, that sounds like a lot of words, but I think there's some real promise in there. The governing body ensures that while staff are held accountable, now here's the next one, an atmosphere in which staff are encouraged to identify and report quality problems as well as opportunities for improvement. So there's been a lot of discussion about what that means, because on one hand you have a climate of accountability, and on the other hand we're looking for a non-blaming climate. So that's element 2. Element 3 is called feedback data systems and monitoring. They're kind of color-coded because in QAPI this has been color-coded. Each element has been color-coded. So the facility is putting into place systems to monitor care and services. And the data for this monitoring comes from a whole bunch of sources. This is to monitor the processes and to monitor the outcomes. And obviously you can get monitoring data from your MDS quality measures, the ones that are generated. There might be state report cards. You obviously have the nursing home compare. You have whatever came out of your own survey for a very minimalist approach to monitoring. And then you can go on and think of all the various systems that could be monitored, but it's very explicit that it's going to include getting the feedback of residents, of family, and of frontline staff. So those are parts where I see opportunity for social work. And it includes monitoring and tracking adverse events and the kinds of things that are reportable in the state or federally. So all of that is clearly part of it. Also complaints. It's expected that you could take complaints which come in as they come in and kind of turn it into some kind of data that can be counted and looked at. So element 3 really concerns the information base, and it's one thing to have a lot of information and another to try to make it usable. So we'll be coming back to that. Element 4 is performance improvement projects, and that part can be in some ways the most exciting, I think. We call them PEPs, and these are particular projects that are a little more elaborate. It's a concentrated effort on a particular problem in one area of a facility, and it involves gathering data systematically to clarify issues and intervene for improvement. Basically, you identify a problem that's important. It's supposed to be done in an area that would be considered important, and it's at one point we had language like high risk, high volume area, but I don't see that there anymore. This has been modified many times. Here it is. An area is important and meaningful for the specific type and scope of services to each facility and the kinds of problems the facility has had. So that's the language they settled on. So it's got to be on something important, and then the project has a kind of a shape. You have You measure to see what kind of a problem you're dealing with. You intervene to try to assist with that problem. You're going to monitor to make sure the intervention is working, and then you remeasure. And then you monitor to make sure you're really doing the intervention. It could be about answering call lights, and you would want to make sure you're really answering them, and then there's some ultimate outcomes you're trying to look at. And the last element is called systematic analysis and systemic action. So the facility is supposed to use a highly organized, thorough, structured approach to determine what problems they're going to be working with and how to work with them. And the main buzzword in this is root cause analysis. They'll be expected to get to the root of the problems that they're dealing with and not just assume that the problem belongs to whoever forgot to answer a call button or whoever was most associated with the immediate problem, the person who gave the wrong medication. So we're looking for systems issues. So those are the five elements, and I went through them pretty fast. Root cause analysis is a big part of it. Getting to the actual of the problem. I have that little picture, Merce, and then have you caught up to? So in applying the five elements, I just had a picture of the roots. I think it might be in the wrong place. So in applying the five elements, I mentioned they're not in any particular order. They're supposed to be mutually reinforcing. They're all interrelated. And we have heard over and over again that these are a framework that still need action plans to get QAPI going in a nursing home. You'll need all hands on deck, and you still need to you still need a certain set of skills. So I have this little cartoon there because we've talked about framework so much. And so in the first frame of this cartoon, the woman is saying, "What do you do for a living?" And the man says, "Well, I'm working on a framework to allow construction of large-scale analytical queries on unstructured data." And she says, "Oh, I'm a little turned on by that." And he says, "Settle down, it's just a framework." So that is also something for us to remember, that it is just a framework after we spent about half a year on that framework. So the action steps develop a very deliberate, obviously leadership has to I'm on to action steps now, Merce. Leadership has to develop a way of assigning, who's going to do what, and set up who's in charge. Have to develop a very deliberate approach to teamwork, and typically there's a steering committee, which would be a kind of a high-level team that's working on QAPI. It should involve a lot of different disciplines, and it should involve levels within discipline if possible. There was some hope that maybe residents or family members or board members might be part of a steering committee, though I haven't seen that happen yet. And then of these performance improvement projects are also done by teams. At any given time, perhaps it would be possible to have one or two going at different levels of completion. The bigger the nursing home, the more likely you could have more projects going, and also the more competence that have been developed in the nursing home. So you have to develop this approach to teamwork, a QAPI awareness campaign, QAPI, I'm calling it QAPI too, a QAPI awareness campaign, trying to make sure that everybody working in the nursing home knows about it, and making sure that everybody, that family members know about it and residents know about it. Taking your QAPI pulse with a self-assessment, and there were self-assessment tools for this. developing the plan. There's these comes time to think about the performance improvement projects. There needs to be a structured way of identifying the performance gaps through data. You need to there is a recommendation that these performance improvement projects be chartered. Now, you don't have to use the word charter, but it means that somebody should be commissioning it up higher in the organization, the administrator, maybe the human resources director, but usually it's the administrator. And it shows that they're interested in having it happen. They're providing the resources. They've established the goal. They've established the team who's going to work on it, and then it gives sort of a legitimacy to the whole thing, and that the interest in finding the results at the other end. So that's kind of the general idea of the charter. You go to the next slide. We have a resource. I was going to try to show it to you, but I don't know if it's worth it, Merce, since
Rosalie, I do have it loaded up, so it's also on the website, the link, but I can just go through a few of these pages.
This is called QAPI at a glance, and it was meant to show how you could work through it. Okay, why don't you go ahead, Merce?
Right.
We won't spend too much time on it, but if you open it up.
And I've just been showing people the kind of information they can get there. Then on page 7 of the document, it's talking about different scenarios. Whistling Pines.
Whistling Pines. If you're looking at Whistling Pines, this was an effort to show how a problem might have been dealt with in the old system and how it could be dealt with in the new system, where you're looking at this. This was a problem that involved a not finishing all their food, and there seemed to be a problem with maintaining weight, having unplanned weight loss. And in the old system, there would be some education about it. Maybe there was a citation at the start, and that's what got them involved with it. So you'd do some training. Under the new system, you'd be doing all sorts of things to try to look at the evidence around who doesn't eat. And you would try to develop a program, and so it walks you through that. You'll see there's a 5-element slide there. There's action steps, and that's basically what QAPI at a glance has. And at the end, there's a bunch of other resources. So it's definitely worth you're looking at. In working on QAPI. There's been an emphasis on tools, yet we don't want to be devoured by tools. You know, if you're a hammer, everything needs nailing, and we don't want to get so centered on tools that we forget what we're doing. That being said, it's helpful to have some organized tools to walk through whatever it is you're doing, whether it's developing your plan or making sure that you sort of run a QAPI performance improvement meeting, or how you would document the steps of a performance improvement project, and so on. So these tools we call QAPI process tools. Those are any tools that are designed to make the process go smoother. And I think that there are about 20 of them. When you go to the CMS website, that's also referenced on these slides that you'll see later, some tools have already been introduced, and CMS is planning to introduce a bunch more tools and also make tools. They're also I've also given those tools to the quality improvement organizations, the QIOs, so they're kind of out in the open now. Now, these tools are not mandatory. These are things that might be helpful. Because an organization could have all the tools, in their kit that they possibly need for this. But then there's another kind of tool that we call the topic tool. Those are measures and tools and protocols that are related to a particular topic, whether it's a total program for managing falls, or one of the examples that are often given is Interact 2, that some of you might be familiar with. That Interact is a system to try to identify changes of condition in a very prompt way, with the ultimate goal that they'll be treated appropriately, changes in health condition, and also that you won't have unnecessary hospitalizations. And that's a complete system. It has 4 or 5 different forms. It has a way that people, the nurses and others in the nursing home would interact with physicians, ways of keeping notes. So there's a huge amount of material in that one set of tools, whereas you could also just have a way of measuring anything, quality of life, satisfaction with A, B, C, D, and E. So there's a lot. There's observational tools to take a look at the physical environment. Is it cluttered? Is it noisy? Etc. So there are a ton of tools related to topics. And these days, the ones I'm seeing in use the most are the Interact tools around hospitalization, and the OASIS tool has come into its own. It's kind of a training package. I believe it's a multiple session, comprehensive training package to teach nursing home staff at all levels how they might manage so-called behavior problems without off-label use of antipsychotic drugs. So that's a set of tools. And at one point, as the QAPI technical assistants, we were going to start looking for tools out there, and we realized that that's crazy because there are so many. We're talking about thousands of different tools that are available to measure things. Now, it may turn out that with the things that some of us as social workers may care about the most still might not be adequate tools addressing the topic, and we might have to invent some. But there are lots of tools out there. Those of you who are familiar with Advancing Excellence in America's Nursing Homes, AE, will know that there are tools to deal with specific areas there, and they're testing a new one about individualized services. So the slide that has that circle is about the Plan, Do, Study, Act cycle, PDSA, which is the basic shape of a performance improvement study. There are a lot of different kind of acronyms, so you can see something that's similar that might use different initials. But the idea is you plan for what the problem is, then you carry out your intervention and you study it, and then you decide, has this helped? Is it something we want to adopt? Is it something we want to modify, or something we want to scrap? If it's being modified, the cycle keeps repeating. Now, the idea of PDSA is usually that you try to do your intervention on a smaller group of in the nursing home, a subset of the residents or a subset of the units or something like that before you go to the entire home. But the PDSA cycle is a major component of QAPI. And then I have a few root cause analysis tools. This is going to be reminiscent of, I think it's a Woody Guthrie song, or children, how they say why, and why that, and why is that. So the 5 whys is a rather, it's the tool that people like the best in nursing homes where we did a demonstration project. You start with the problem. Mrs. Jones missed her physical therapy this morning. Well, why was that? Well, because nobody got her up in time. Well, why was that? And et cetera. And so it's a good tool for thinking things through, but you can see that one of the problems with it is it leads you to just one solution when problems are sometimes more complex than that. I've heard of other kind of funny problems that occur in operation, like, we think we're there at number 3, but we're looking for 5 whys. Well, that isn't obviously the point. This next tool is called a spoon tool, and it's another way of getting into the various facets of the problem and trying to look at multiple issues that might be involved in order to figure out where to intervene. And a third tool where I don't have a picture is a process map, and that's really a good concept. In fact, there's a picture of it in here. I want to if you go to Getting Better All the Time, to make this group aware of this resource, and Merce has it, so I'm going to ask her to open it. Getting Better All the Time is a document that was provided that was developed in a collaboration between 2 nursing homes in Brooklyn and the Alzheimer's Association of New York City. They developed an approach. Ann Wyatt, who is a social worker, WYAT, was instrumental in doing this. And if you open it, Merce, and see,
I've got it opened, and I'm
so if you can
table of contents.
Yeah, the kind of things I'd like to show them is how. Yeah, so if you can show them, there's a process map. I think it's about laundry. I forget for sure, but all the steps in getting the clean laundry back to people. And that kind of process could be done with anything. You could wash food cold. Well, who handles it? And or why? There was a great project in one of our demonstration homes about why people weren't getting choice of food, and they went through the whole chain of all the different programs and departments that are dealing with food and where things could go wrong. So a process map is good. That document has other kind of neat things in it, and it's really worth looking at. You'll see ways of getting a handle on data and making it meaningful to look at change. Or I recommend it highly. It's one of my favorite resources. So I just wanted to mention it. Now I'm going to go very quickly because we're starting to run out of time, I can see, and I was hoping to hear. Not to hear, I know I can't hear it, but I was hoping to see what kinds of issues might be in your minds, because I could be talking about this for a long time. So we did a demonstration project in 17 homes in 4 states. This was part of what our contract asked us to do, to identify volunteering homes and then using them in such a way that we would have a balanced group of nursing homes, some of them being part of multi-facility corporations, also known as chains, and some of them being freestanding, some larger, some smaller, and some with more or less experience with QAPI-like activities. That was the general rubric, but then within that, CMS was hoping, and we managed to achieve it, to have some homes in the very crowded urban areas, some homes in rural areas, some homes that they wanted to have at least one home, maybe more, that had dedicated itself to culture change and really had changed that culture towards neighborhoods or towards small houses, and a lot of different ways of empowering frontline staff as well as residents. Because one of the concerns was, will QAPI work synergistically with the culture change that I'm sure a lot of people on this call are enthusiastic about, or will it get in the way? So we did indeed have a home that was doing the culture change. What the homes were expected to do, I'm not quite sure where I am with the slides now, but they were asked to develop a QAPI program using the 5-element framework, and they received technical assistance, individualized technical assistance from our collaborators working in our QIO. They also received a lot of online materials. We had a big website. We had a lot of tools up there, draft versions of the tools that CMS is going to be releasing. And they also, this was pivotal, they were participating in a learning collaborative. That means the 17 homes were having in-person meetings. We had hoped to have 4, but in the long run we only had 3, so we didn't get to all 4 states. But they would come together for 2 days, and it was a mixture of guest speakers and interaction and work groups and discussing their own issues with QAPI. So these meetings were, everybody loved these meetings. The meetings also had some homework associated with them. The nursing homes did the storyboards, and it made the project move ahead. It also had webinars, and those webinars I'm sure will be available for viewing just as these webinars are. We had a 3-part series on root cause analysis where each facility identified a problem. We had a lot of instructional material out there on the web. So the one that says variation in nursing home and demo participants, I also sort of described that. Those states that were really different in terms of their labor force, the kinds of policies involved, the reimbursement and regulatory policies, and their whether they use the QIS survey system, if you're familiar with that. The purpose of this then was to learn from the demo homes about the experience of implementation, the strategies they used, the speed at which they were able to do it, the accomplishments they had, their challenges. And we're also trying to get feedback on these tools. And we were identifying case examples and trying to help define best practices. So we found with these 17 homes was that they had almost all made progress. We for sure a good thing. We would have been devastated if they hadn't made progress, but they did have challenges in doing it. And one thing is that there were a great many leadership changes that occurred in these 17 homes over the course of 2 years. The demonstration project lasted for 2 years, and about half of them they had major changes. Major means at least 2 changes in administrator, DON, and or whoever they put in as the QAPI lead or owner. And some of them had a myriad changes. So there was one home that really didn't make much progress. They had experienced way too much, but they re-geared in the second year and got going again. But they didn't get to the point where they did performance improvement projects yet. The other thing besides change in personnel was that these nursing homes are doing other things besides worrying about QAPI, even if they're in an exciting national demonstration. A whole bunch of them were introducing electronic medical records and all the issues about that and the retraining of personnel for it. Some of them seem to have an unusual number of audits. I remember we had one that had a the usual state survey, of course, and then they ended up with a Medicare audit, and then lo and behold, they had an OSHA audit, which is very unusual. But each one of those took a lot, and it was a home where the person who was managing the QAPI demonstration, he was the MDS coordinator, suddenly found himself the acting DON as well as MDS coordinator, and there was a lot of change. So that's the kind of thing I mean. And some of them had census problems and exacerbated sometimes by high death rate and their long-term care component. A lot of them were trying to gear up to do more post-acute work. So they were busy. And if you have the combination of change of personnel and sense changes, it's going to be even more challenging. So I think that got me to resist to nurse, and then let's see. So basically, implementing QAPI is complex. Well, it really isn't easy, and it required a shift of thinking. It can't just say it comes naturally. And those that did use structured tools got further ahead. There's no doubt about it. The learning collaboratives really helped. They liked it a lot. The nursing homes varied in how they approached it, what they decided to do first, whether they were going to get their leadership involved before they went to their entire staff. The threat in the demonstration, we did a rating system for the implementation. Made the result that we were looking at was the extent to which they had implemented each of the elements, and then you could have a score by element, and you could have an overall score. And what we found was that the success in implementation wasn't predicted by 5-star rating status. That was one of those things that was varied on purpose. It was not predicted by the degree of culture change or person-centered care that was there. It was not predicted by the corporate resources that were lavished on quality, because some of those nursing homes were part of corporations that had a huge amount of material on quality on their own websites. They had dashboards and so on, and lots of learning materials. But about the only thing that might have predicted it was if you had too much change at once and too much turnover of personnel. That did make it more difficult. The corporations were very helpful in getting QAPI going. The great challenges were using data systematically, the comprehensive idea of performance. Dashboards are one of the tools that have been given attention. Trying to create, just like in your car, trying to create an overview of data that's not too overwhelming, that can be looked at across disciplines and across departments, and making that sort of meaningful. And that was hard. That really hard. Building in a systematic way of getting resident and family input was hard. I mean, most facilities are doing some sort of annual review, annual satisfaction survey or some kind of survey, whether it's my interview or whatever it might be. There's lots of vendors out there. Some of them did more than one. The problem is response rates are poor, so that's an issue. Another problem is trying to get that for people in subacute units, because an annual survey isn't going to capture very many of the people who come in and out in 20 days, give or take a bit. So that was a problem. Structuring PIPs was difficult, and sometimes those nursing homes, they were really troopers. We loved working with them, and they did some great things. They still. It was a lot for any one nursing home to accomplish in the 2 years, I have to say, because it is meant to be a new way of thinking and a new way of doing things. And I wish I had time to give you real examples that would make it come out better to you. So it was sometimes hard to get out of the disciplinary silos. We had one nursing home that did a wonderful job of involving all their shifts and all their levels of nursing, but they didn't get out of nursing. And so the different ways that it happened. From the demonstration home perspective, I mean, they did see the advantage of QAPI. They thought it was a real practical approach to problem solving. They liked its structure and its comprehensiveness. They did say all the tools we had were overwhelming, but too many at once. There was a lot of hope that the survey process would be compatible with the QAPI process. There was some discussion about that if you're going to be doing, if you're trying to have a blame-free culture, how does that really work? And we know there's so much variability in the survey process, and there's going to be a lot of survey training that's related to this. When QAPI is rolled out nationally, which is has done now, CMS has started a QAPI website and has a lot of materials out there. They launched their website. They've got their tools, as I said. Then they would expect to have a lot of partners. Saying it takes a village to do QAPI. Some of the partners could be the quality improvement organizations, perhaps in states that have good structure for advancing excellence. Those lanes would be useful. Local area networks for excellence. State nursing home trade associations are obvious partners. Consumer advocacy groups, maybe. There's a tremendous amount of interest in this. Professional associations could be involved. It's a little tricky. I see that we're getting towards the last 15 minutes, right, Mer? So I'll abbreviate this some. But the professional associations, I think, are important. This is not supposed to be a within discipline effort, but yet each professional group needs to think of what quality is in terms of their own discipline. We met with stakeholder groups a lot, in the local areas of the demonstration, and also several times nationally. NHSW was at the table whenever we had a national stakeholder meeting, which was twice. The dietetics group was extremely interested in QAPI, and I have voluminous correspondence with that group about how they could manage it. But ultimately, it's in AMDA, the Medical Directors Association, is very interested, and the Association of Nursing of DONs, NADANA. So there's a lot of interest. And we expect learning collaboratives to spring up, and we think that's going to be a very important phenomenon, kind of working together to go through the steps. Our learning collaborative was nice because we didn't have too many facilities, and that would sort of be an issue. I expect nursing home corporations will, of course, lead their own group. So there are some links to CMS resources on the next slide. And if we're not going to do it now, but if you go to the YouTube video later, you'll see a video presentation that uh, quite convincingly, I think, explains what might be the business case for doing QAPI, why you should do it besides the fact that there's going to be a regulation about it. And there's also the go.cms.gov is where you'll find all the resources on the QAPI website. So you find QAPI at a glance there. You'll find other tools that now I'm getting to the point where it's about social work, and I've been talking about that all along. I think there are some implications for social work practitioners and educators and those who do staff development for social work. The natural affinities are obvious. There's an emphasis on quality of life. There's an emphasis on teamwork. Hear that resident voice and that family voice. There's opportunities to create performance improvement projects on the kinds of things that you might that involve psychological or social well-being. I mean, it's very clear that high risk, high volume, high importance doesn't just mean a health problem. If people are depressed, if people are miserable, that's considered high volume, high importance, so that they can be the subject of performance improvement projects. And I think there were 47 different performance improvement projects done by our 17 demonstration homes. They were all over the map. I have a lot more detail in our evaluation, and if people want to send me email, I can share more information. One of the challenges is making QAPI work in post-acute areas or TCUs, making it work in Alzheimer's units, trying to figure out what evidence is all about, and then incorporating it into everyday work. I mean, we know nursing homes are busy and nursing home social workers are busy. I think that anyone who wants to volunteer to give some leadership to QAPI and the nursing homes where you're working would be very, very welcomed. And that's where the opportunity comes in. And the fact that I think some workers do have some communication skills and some ability to work within teams and to think systems. So with that, Merce, I'm going to quit for a while. We haven't left much time, and we started late, but wondering if anybody has sent you questions or comments.
Yep, we have some questions. Rosalie, thank you. This was really, really helpful to get an overview of what you've been doing with 17 nursing homes and what the other 16,000 nursing homes are going to be doing this year. So you talked.
What we've said all the time, from 17 to 17,000.
Right.
How are we going to bring this to scale?
The question that came in about, say the social worker is pretty enthusiastic about this, seeing it as an opportunity to maybe get some attention on some psychosocial issues, but the administrator is not too excited about it. Doesn't understand the value of getting social work involved and kind of leaning more towards nursing issues. Any response to that?
Well, I mean, I do think that nursing is the largest discipline in nursing homes, and there's always the challenge that we want the DON, for instance, to be a big leader for QAPI and sort of make it possible for nursing staff at all levels to be involved and yet go off into other disciplines. As far as social work seems to pop up on these steering committees, and it is kind of a natural because social workers tend to control various aspects of the MDS, and you know that from your own work, Merce. They're likely to fill in a few sections, and it does seem as though it's hard to imagine that if a data-driven system is being used to try to figure out what to work on, that some of these areas like working with reducing psychoactive medication, especially off-label use of antipsychotics, won't pop up. I think administrators may not always see the immediate area of social work. That's one of the issues of being a nursing home social worker. Sometimes you're all by yourself or one of two, and need to volunteer. So that I think and learn along with the rest of the staff to learn what some of the technology is. Social work, of course, is working with the admissions and discharges, and that's another big arena. I don't know if that answers it very well.
Yeah, I think it does. It addresses it. The other thing that comes to mind is that this would be a really good natural partnership between schools of social work and local nursing homes, because the schools of social work they're always looking for research projects and evaluation projects for their students and faculty to be involved in. And so please don't overlook, those of you practicing in nursing homes, please don't overlook your local school of social work.
I think that's a great point, Merce. There's, and we saw some of that kind of work going on in the demonstration where facilities would be reaching out to local universities. It was often schools of nursing, but sometimes gerontology programs. They were reaching out to various entities to try to do some of the getting the feedback going from residents, and yes, I think that's a great idea. Maybe schools of social work will be interested in creating learning collaboratives. They might have to combine with another discipline or two to be in the spirit of QAPI, a few more academic disciplines.
Yes. So, the learning collaborative sounded like a really important part of your pilot study, and that was prompting me to think, well, so how does that work after your pilot study? Will there be a role for learning collaboratives, or will people make that themselves?
In the new scope of work for QIOs, they have been emphasizing that QIOs should be doing learning collaboratives in their local area, and there's a new acronym LAN, LAN, which is not the same as Elaine, so it's a local area network, and so there's permission to do learning collaboratives, and it was our QIO colleagues who really emphasized the beauty of doing this, and I did see it working very well. Now, it's still. I would have liked to have it be more intensive over a shorter period of time with more meetings or something like that. But so there is the vehicle, and I think that trade associations will be interested in getting collaboratives together. I don't know how expensive the process actually is. There's some training materials that are also going to be released. I should have mentioned that. While our team have been working with CMS on training materials, and there are learning sessions about QAPI that have been developed. We're calling them the Big Six. They somewhat follow the arc of the 5 elements, but they get into there's quite a bit of content. They're suitable to be done in webinars and shown in big screens and then stopped, to be particularized to the whatever is going on in the particular nursing home, and there's various exercises that can be used. So those big training sessions I think will be released quite soon, and they'll be available for, once they're out, of course, they can be modified however the various homes might want to modify them, or the trainers might be consultants, they might be professional or trade associations, and so on. There's also there's the Big Six, there's the small 3, which are designed to get frontline staff enthusiastic about QAPI. We in our demo we had some staff where reading ability in English was very low, and the concept seemed abstract, and so there needs to be some way of making them real. And then there's there's one learning session that's meant to be to explain QAPI to the public, to residents, to family members, and so on. So some version of those kind of web-based learning tools will be out there too. I mean, yeah.
A very specific question that came in, and it looks like it's going to be our last question. The writer has said, I really like the slide of the 5 whys. How can staff prevent asking why only to find out who?
That's a very good question. No, I don't think it works that way. You sort of start out with who did the cold food, or who did answer the call light, and before you know it, you're getting to short staffing, you're getting to difficult suboptimal use of staff, or not having the right equipment. There was one that involved a near miss, somebody who was slipping while getting assistance with toileting, and it got beyond the who. It was a very seasoned CNA who had sort of the room to grab something, but they ended up constructing shelves in all the lavatories as a result of going through their 5 whys. I think it's a good caution that person raised. I think that a lot of the demo facilities really spent some time thinking about this. That if and putting it in writing that their some of them did that it was not their intention to point fingers at staff members, or that it's unless of course the problem is one of conscious neglect or malfeasance. That's a whole different matter. But if you're really even if somebody forgot something, well, I mean, we had dialogue with one of our facilities. I mean, what in the world? Why would you retrain somebody not to forget? And every once in a while, someone forgets something, and training is kind of a weak intervention. System change is stronger, trying to shore things up to make it easier. But I guess the true answer is you can't avoid if somebody is going to try to get to who at the end of all the whys. But I think we would expect the answer to be all of us. We're all involved with this, and we hope that there's going to be some ownership of quality. And this is meant to be aspirational and sort of inspirational, and that's why I think there's a lot of possibilities in it. And yet the difficulty is, everybody's busy and they're going to be inspected on this, and how can we maintain sort of momentum for getting everybody's good ideas out, which is another part of it. There's a lot of bells and whistles built into those 5 elements. I have not seen the rule. Nobody has seen the rule. The nursing home division in CMS hasn't seen it. Now it's working through the parts of CMS that develop rules. And so when it comes out, it's unclear what it will contain really. I kind of suspect it will expect that each nursing home will have some capacity for root cause analysis, some substantial knowledge of it, and some of its staff. And it's not clear whether a certain number of PIPs will be expected, or what that how it will really play out. But there's a lot of enthusiasm for this in the two national trade associations, that this could be a really good way of thinking positively about quality. So,
love it. And we'll leave that as our last word. It's another approach of thinking positively about quality, and the details will be coming down the pike, and we can continue to have this conversation through our listserv and also through future webinars.
The details you guys will be inventing yourself, I think.